Hi everyone, welcome back to Christina Screencasts her lectures. So this is for the first lecture of Biology 232 in spring 2018 at PCC. So if you're one of my students, hi, this is for you. If you're a rando, hello, you're welcome to watch me too, I guess. So this lecture is about the brain and cranial nerves. Also, I'm noticing the audio levels are a bit high. I bought a new headset to make better recordings, and I'm still getting it sussed out. So if I'm deafening you, sorry, just turn it down. Okay, so the brain and cranial nerves. The brain is basically a wet computer, and the cranial nerves are the afferent and efferent nerves that bring information into and away from the brain itself. And these are different from the spinal nerves, which hook up with the spinal column. So the brain has lots and lots of functions, and the functions are still being learned about and understood by scientists. There's a lot we still don't know, and that's okay. That just means that there's plenty of PhDs out there for you should you choose to pursue them. So this big wrinkly helmet part that I'm going to outline with my pen here is the cerebrum. And on the back, there is a smaller version of the same called the cerebellum, so it too has wrinkles, just smaller ones. And then we have the diencephalon, which includes the thalamus and the hypothalamus, and the brainstem, which includes the midbrain, the pons, and the medulla. So we'll go through all of these today. So the principal parts of the brain, as I just mentioned and outlined, are the following. We've got the cerebrum, and this is made of lobes. And the lobes are named after the bones that lie over the top of them, so that would make this the frontal lobe, this is the parietal lobe, this is the occipital lobe. And if you were to turn this around, you'd be able to see the temporal lobe as well. The diencephalon is separate, and this is the thalamus, which is a sort of oval structure right here, and the hypothalamus, which is right below it, and that is more of a triangle. It leads down to the pituitary gland. The cerebellum is on the back here, and this has the same structure as the cerebrum, so it has grooves and bumps just like the cerebrum, but they are smaller. The brainstem includes the midbrain, which is between the diencephalon and the rest, the pons, which is this 1-inch long anterior bulge, and the medulla, which is a widened area just above the spinal cord. So here is a photo of the sagittal section of a brain. So if you were to slice the brain down the sagittal fissure, right down the middle, you would see this. So this is looking at the medial aspect of a sagittal section. So let's look at what we've got here. We have the parieto-occipital sulcus. A sulcus is a name for a groove. And these are different from fissures, which are just an extra deep version of the groove. So parieto-occipital refers to the fact that this sulcus divides the parietal lobe from the occipital lobe. The corpus callosum is this structure right here. And this connects the two halves of the cerebrum. So it allows decussation from one side of the brain to the other, and this is part of the reason why your right brain controls your left side and vice versa. Now within the brain, there are fluid-filled spaces called ventricles, and you're getting a window into the lateral one, which if you follow my cursor is right here. Here we have the thalamus, which is an oval-shaped structure, and the hypothalamus is right here. The midbrain is sort of this stalk that is connecting the diencephalon to what's below it. And there's some important structures here and here, which we'll talk about in a little bit. This anterior bulge is the pons. And just below it, this expanded region is the medulla oblongata. This little triangle guy is the fourth ventricle, so it's a triangular fluid-filled space. And it's continuous with the third ventricle via the cerebral aqueduct, which I'm coloring in here. So the spaces I'm coloring in are ordinarily full of cerebrospinal fluid. This structure is the cerebellum. It does a lot of different things, some of them involving movement, some not. We'll talk more about that later. So that's sort of an overview of what you're seeing when you look at that sagittal section. Okay, so let's review the meninges. Remember, the meninges are the connective tissue layers between the skull and the brain that help protect the brain, and they each have different jobs. So the dura mater, this means tough mother. M-A-T-E-R is mother, not mater. Those are different words. It's Latin. And this is the outermost tough membrane. So it actually has two layers. There's an outer periosteal layer, which means next to the bone. And there's an inner meningeal layer. And in a couple places, they separate from each other to make little pockets where venous blood accumulates. So these are called dural venous sinuses. And these drain blood from the brain after the brain has used up the oxygen and glucose in there. And it's also where your cerebrospinal fluid gets dumped into. Your dura mater also forms some supportive structures. There's the falx cerebri, which divides the two cerebral hemispheres. The falx cerebelli, which divides the two cerebellar hemispheres, and the tentorium cerebelli, which divides the cerebrum from the cerebellum. So the dura mater not only covers the surface of the brain, so let's draw that, but it also, if this is a sagittal section, goes down between, so this would be the falx cerebri, between the two cerebral hemispheres and between the two cerebellar hemispheres, and then there's this tentorium, which forms sort of this floor that divides the cerebrum from the cerebellum. The epidural space is the space outside of the dura mater in the spinal cord, which is filled with fat. And this is where epidural anesthesia is administered during childbirth or other procedures where the lower half of the body needs to be numbed. Arachnoid mater means spider-like. So spider-like mother, and that's because it has a spider-webby filamentous appearance. And then the pia mater, pia means soft. So the soft mother is a thin vascular layer that hugs the curves of the brain. So let's take a look at this. Good old cranial meninges. And I want to stress, as I did in class, that these colors are false. So the dura mater is really whitish, as are the rest of the layers. But here they've been colored in just to emphasize their difference. Oh, look, you can see a venous sinus right here. So here's the periosteal layer, and here's the meningeal layer, and you can see that there is a little pool of venous blood right between them. You can also see the falx cerebri here. So the two layers of the dura mater stay together most of the time, unless they're involved in a sinus. Excuse me. The arachnoid mater is right under the dura mater, and there is a thin space between them. It's not very big. That's called the subdural space. So it's the space between the arachnoid mater and the dura mater. So if someone says they have a subdural hematoma, that means an accumulation or clot of blood between these two layers. The arachnoid mater is here in blue, and it has these little ligamentous attachments to the brain surface, which is why it's called spider-like, because it looks like spider webs. And then the pia mater, as you can see, is actually hugging the surface of the brain. The subarachnoid space is where cerebrospinal fluid lives, among other places. And the pia mater, in part, serves to help anchor blood vessels. So the blood vessels do hug the sulci of the brain, but they have to be held in place. And that is accomplished both by the pia mater and by these little ligaments of the arachnoid mater. Other things you can see in this picture. We have white matter. This is myelinated tracts. And gray matter, and it's a thin layer of gray matter overlaying the top. We call this the cerebral cortex. So this is dendrites and cell bodies. The cortex is where mental computation happens. So it's where neurons talk to each other to perform complex higher order thinking tasks. So if you damage an area of the cerebral cortex, it's possible that you will ablate or get rid of the function of that spot. And that's why all this protective machinery is in place to prevent that from happening. So, meningitis. Anything-itis, whoopsie. Anything-itis means an inflammation of the something. So if you have laryngitis, that means your larynx is angry. But meningitis means your meninges are inflamed. So this is just telling you that your meninges are inflamed. It doesn't tell you why the meninges are inflamed, and that's an important point to make. A lot of pathologies with names like meningitis are really symptoms of a pathology that is caused by a bacteria or by a virus. So you can have meningitis because of bacteria, or you can have meningitis because of viruses. And those two disease etiologies of meningitis are very different because they have a different organism affecting the meninges, and your treatment methodology has to be different as well. So this is most serious in infancy and childhood, although the older people can get it. It's just that when you're this age, people between 3 months and 2 years of age aren't the best communicators, especially if they're more towards 3 months. They tend to communicate by screaming rather than using their words because they don't have words yet necessarily. So if your kiddo is shrieking and has a fever, they can't also tell you that they have a stiff neck, or that they feel drowsy, or that they have a headache. They're just going to shriek at you. So it's dangerous because it often is caught a little bit later than it ought to be. Not because parents are bad, just because it's hard to tell, especially if you have a fussy or colicky baby. So the pia mater and the arachnoid mater are the most likely to be affected, and that's simply because those are soft tissues as opposed to the dura mater, which is a very tough connective tissue. So you diagnose this by examining the CSF, because if there are viruses or bacteria present, they'll also be in the cerebrospinal fluid, and they may even change the color of the cerebrospinal fluid. So I won't show you, but there's some gross pictures on the internet where you can see the subarachnoid space is full of what appears to be pus. It's pretty disgusting. Okay, blood supply to the brain. I'm going to actually change my pen color here. So the arterial blood supply to the brain branches from the circle of Willis, which is an anastomosis. And an anastomosis is a place where arteries diverge and then come back together. So since your brain is important and keeping it alive is a priority, because if you have no O2 for even 4 minutes, it does permanent damage. Sometimes it makes sense to have backup blood supplies to the brain. So you have vertebral arteries, and your carotid. So your vertebral arteries go through the transverse foraminae of your cervical vertebrae, so they're encased in bone, and your carotid arteries are just deep in your neck, protected by muscle and fat. These two branch and eventually meet at the circle of Willis. So the cerebral arteries come up like this, and then they join to form the basilar artery. And then they meet up with the internal carotids, which re-anastomose and supply other brain regions, so it creates a little circle. Circle of Willis is named after the guy who discovered it. It's also called the cerebral arterial circle. So this one describes more what it is. This one is named after the guy that found it. So the vessels on the surface of the brain do penetrate the tissue. And that's necessary, right? Because you have to get blood and oxygen and glucose to where it needs to go. So this uses up about 20% of the total body oxygen and glucose acquired. And that changes depending on activity. So blood flow to a particular area increases with activity to that area, which means that if you want to, you can use a functional MRI machine to observe changes in hemoglobin in a particular brain area as it lets go of oxygen because that brain area is using the oxygen. So that's how you can, in real time, watch what the brain is doing if you show it certain stimuli. So this is a really powerful technique for cognitive neuroscience, and they use it a lot, just to look at the overall brain states that are achieved during particular tasks or processing requests. Okay, so the blood-brain and blood-CSF barriers. Note that these are different. So blood-brain is mediated by astrocytes, and this is contingent upon tight junctions in endothelial cells and astrocytes wrapping around those tight junctions. So the tight junctions between the cells that actually make up the tube of the blood vessel seal the epithelial cells together, and the astrocytes wrap their feet around those capillaries to prevent things from passing through. So this helps to protect your brain tissue from toxins or pathogens that could be present in your blood. So that means that proteins and antibiotics can't pass. They're too big to get through. Now, if I tell you that antibiotics can't pass, what do you think that means for the treatment of bacterial meningitis? That means that oral antibiotics and intravenous antibiotics would probably not work for this purpose because stuff that you ingest goes into the blood, can't get through. Stuff that you inject still goes into the blood, also can't get through. So bacterial meningitis can be really hard to treat, and that's one of the reasons that it's so dangerous. The blood-brain barrier is permeable to lipid-soluble material, and that's because, of course, the middle of a phospholipid bilayer is lipids, and lipids can get through other lipids just fine. Also permeable to alcohol, as we know. This is why we get drunk. That's why alcohol affects the brain. Oxygen, and that's good because we need that. CO2, that's good too because we need to dump that. Nicotine, if you're a smoker or nicotine user, and anesthetics. So this is how you get knocked out if you go under general anesthesia rather than local anesthesia. There are a couple places in the brain where there is a breach in the blood-brain barrier. And these are organs in the third and fourth ventricles at breaks in the barrier where blood has direct access. So one example of this is the capillary beds of the pineal gland so that melatonin can be released directly into the bloodstream. And another example of this has to do with the pituitary gland. Again, direct access for hormones to the bloodstream. So we'll cover those things more when we get to the endocrine system. So this allows the brain to pay attention to blood glucose, to pH, to osmolarity, and to other variations in the brain so that homeostatic feedback loops can be enacted and maintain homeostasis. It also allows a route for the HIV virus to invade the brain if an individual is infected with the HIV virus. The blood-CSF barrier, so notice not blood-brain but blood-CSF, this is a barrier to the passage of material out of the blood with the filtrate as the cerebrospinal fluid is formed because CSF is a blood filtrate. It is filtered out of a capillary bed called the choroid plexus. So let's write that down there, blood filtrate. So at the choroid plexus, which is a specialized arterial capillary bed that is pressurized, there are endothelial cells with tight junctions that are covered with ependymal cells, which themselves are joined by tight junctions. So that makes a double-walled barrier between the blood and the cerebrospinal fluid that is being formed from the blood. So that's what that is or means. Now, cerebrospinal fluid itself. This is between 80 and 150 milliliters of clear fluid that fills the ventricles and canals and bathes the external surface. So why is this number a range? Well, that varies with body size because your head size varies a little bit and so does your brain size. So this reflects natural variation and also developmental variation. Your brain produces and reabsorbs about 500 milliliters a day on average. Now the rate changes throughout the day. You do more of this when you're asleep, but it works out to be about 500 mils. So as long as you are producing CSF as fast as you are absorbing it, your total amount will stay the same. So I told you it's a blood filtrate, but it's not identical to blood plasma. So it has more sodium and more chloride, but less potassium and less calcium. So calcium and potassium are important. Potassium in particular because potassium has a really strong influence on resting membrane potential. So we know from action potentials that neurons at rest tend to have a lot more potassium inside than outside. So keeping the CSF a low potassium environment is really critical. Similarly, if you want to make an action potential, you have to let a bunch of sodium into the cell. So the CSF is a naturally higher sodium environment, and that facilitates the action of neurons. So this ion distribution is for a reason. So other functions, buoyancy, your brain sort of floats neutrally. It doesn't sit down on your cranial floor. It also protects your brain from crashing into the inside of your skull. It provides chemical stability, so it rinses away wastes and creates an optimal ionic environment for action potentials, as I discussed above. And this component I mentioned in lecture, remember, I talked about how during sleep, the rates of production and reabsorption of CSF increase a bunch, and that helps flush beta amyloid plaques and other cell wastes from between your neurons. That's why if you don't sleep for too long, you die, and it's why you suffer cognitive deficits if you don't sleep. So sleep is important. Get it if you can. So this escapes from the fourth ventricle to surround the brain at a couple different spots. These are called the lateral and median apertures. And it's reabsorbed by the arachnoid villi into the venous sinuses. And you'll see another view of this in a minute. So here's that pesky slide where all of the arrows moved. So I wonder if I can make this better. Let's see here. So maybe I can move this. Nope, they're all stuck that way, so I'll deal with that later. Okay, so back to business as usual. I'm going to just use my pen to redraw these lines. So the lateral ventricles are these things. There's one on each side, so you can see them better here. If the ventricle system is a weird bird, the head of the weird bird is the third ventricle. These are the lateral horns. The neck of the bird, so I'm going to draw a line down it, that's the cerebral aqueduct, so let's write that too. And the cerebral aqueduct widens between the pons and the cerebellum into the fourth ventricle. And the fourth ventricle narrows inferiorly to form the central canal of the spinal cord. And here you can also see the lateral apertures right here, and up here is the median aperture. Here is an actual human brain, so you can see the two lateral horns of the lateral ventricles from the top. Also see the shreddy business right here? Those are sheets of choroid plexus, so that's where your CSF is being made. All right, so the internal chambers in letters. Let's go back to pen. So the lateral ventricles are found deep inside each cerebral hemisphere. The third ventricle is a single vertical space under the corpus callosum, and it is enclosed by the thalamus. The cerebral aqueduct passes through the midbrain and widens onto the fourth ventricle, which is between the pons and the cerebellum. And that narrows inferiorly to run down the spinal cord. It's lined with ependymal cells, which help keep those ions in check, and it contains the choroid plexus of the capillaries that produce CSF, which, of course, those capillaries are lined with ependymal cells as well. Okay, drainage of the CSF from the ventricles. Oh. All right, sorry about that. My dog walker came to pick up my dog. And by dog walker, I mean my brother, who I make do it because I'm older. Anyway, CSF drainage from ventricles. So, the CSF does not stay in the ventricles. As we mentioned, the brain floats neutrally buoyant. Oh, he's back. He forgot his headphones. So the brain floats neutrally buoyant in the brain case, and that means that the CSF has to get out somehow. So it gets out via the lateral apertures. There's two of them, one on each side. They're lateral, as the name suggests, and the median aperture, which is in the middle on the anterior. So in the next slide, we're going to see a sagittal view of how that flow happens and how it works. Okay, so on the left side here, we have a schematic diagram, and this includes the heart and lungs, and that's because, of course, if we know that CSF is a blood filtrate, that means it must come from arterial blood. Ta-da, here it does. So you have the three choroid plexuses of the ventricles, so the lateral, the third, and the fourth. These flow through the interventricular foramina. So inter means between, ventricular means ventricles. This is just a hole that allows the two lateral ventricles to communicate with each other and with the third ventricle. Into the third ventricle, that flows through the cerebral aqueduct into the fourth ventricle. And from the fourth ventricle, the CSF flows out through the lateral and median apertures and occupies the subarachnoid space. Or it flows down the central canal of the spinal cord, as the case may be, because you know you need to both bathe the tissues on the outside in fluid and have a fluid core. When it's time for the CSF to get sucked back up, it is reabsorbed in the arachnoid villi, which are little granulations of arachnoid matter that poke up into the dural venous sinuses. And from there, the used up CSF enters the venous circulation, and it's eventually cleared out in the urine. So this is the words version of it. Here is a picture of the same, just showing you via the arrows the directionality of all of this stuff. All right, reabsorption of CSF. I promised you another picture of arachnoid granulations, and here they are. So we've got 1, 2, 3 here. Now I'm calling them arachnoid granulations. They're also called arachnoid villi. Singular is villus. This is a spelling point. You can use either term, doesn't matter. So arachnoid granulation is spelled like this. So that's how your CSF gets reabsorbed. Now, what happens if there is a mismatch between the rate of reabsorption and the rate of production? Let's say, for example, that there's a blockage of CSF drainage. Then we get hydrocephalus. So hydrocephalus is a condition in which CSF drainage into the dural venous sinuses is prevented for some reason. So most commonly, it's a result of developmental malformation where, for whatever reason, too few or no arachnoid villi form. But it can also be caused by meningitis, and this will happen if inflammation pinches off the arachnoid granulations, or hemorrhage or injury. So hydrocephalus that is congenital happens because of developmental inflammation or malformation, but there are other causes as well. So if the production of CSF continues, that causes an increase in pressure because fluid is incompressible. So you can't take a volume of fluid and make it into a smaller volume. So if you add more and more fluid to a closed bony space that can't expand, it begins to press on the brain, and that is damaging. So that's what we call hydrocephalus. In a newborn or a fetus, the fontanelles, remember these are patches of non-ossified mesenchymal tissue. This internal pressure causes an expansion of the skull, so tissue in response to the pressure begins to be deposited to the fontanelles, and that creates a large head size and a large brain case with more soft areas on it. It also produces damage to the brain tissue because of the pressure that that fluid is exerting on the tissue itself. So to treat this, because hydrocephalus as a congenital malformation is fairly common. It's not super common, but it happens often enough to be pretty well known and treatable. A neurosurgeon is going to implant a drain which will shunt CSF to the veins of the neck or down into the abdominal cavity. So the fluid has to go somewhere, and it can't go out to the air because that would mean that things could crawl up the tube and hurt your brain. So instead, it's just rerouted to an alternate area of your body that can afford to have a little bit of extra fluid. Okay, the hindbrain. So this is hind, but also technically inferior. So this is the rostral end of the brain, and this is the caudal end of the brain. So the axis of brain directionality is not straight. There is an arc directionally that goes from rostral to caudal. So it would be correct to say that the inferior frontal cortex is rostral relative to the precentral gyrus, where motor planning occurs. So that's just how those directional terms work. Now, we are talking specifically about the medulla oblongata, which is this widened region here. And notice that it takes the form of white matter. And these come in tracts surrounding nuclei of gray matter. So remember, in the central nervous system, a population of cell bodies and unmyelinated axons surrounded by white matter is called a nucleus. And there's one. So it's only about 3 centimeters long, and it's basically an expanded superior portion of the spinal cord. It contains both ascending and descending nerve tracts. So as we know, ascending equals afferent or sensory, and descending equals efferent or motor, just to characterize what we're talking about. Okay, the nuclei of sensory and motor cranial nerves, so nuclei are again gray matter surrounded by white matter, and this is the nuclei of the cranial nerves, so the cell bodies of those nerves. And that's cranial nerves 9, 10, 11, and 12, so the last few. Now in the medulla oblongata, it, along with the pons, is sort of your life support portion of your brain. So, for example, it will adjust the rate and the force of your heartbeat. So your heart rate in beats per minute and the contractility of your heart according to your need. So if you decide to go sprinting off down the hallway, the cardiac center will notice that and increase the rate and force of your heartbeat so that your blood gets moving in an amount that is commensurate with your activity level. The vasomotor center adjusts blood vessel diameter. So again, if you go sprinting off down the hallway and there is this increase in heart rate and force of heartbeat, your vasomotor center may dilate your blood vessels a little bit so that blood pressure doesn't get too high. There are also respiratory centers that control the rate and depth of breathing, so how deeply you're inhaling and exhaling and how fast you're doing that. And there are also reflex centers for a variety of involuntary reflexes, so coughing and sneezing, gagging, the non-oral phase of swallowing, vomiting, salivation, sweating, and some movements of the tongue and head as well. So it's a really important piece of your brain, even though we don't do our big, important hominid thinking with it. And if you damage it, there's a very good chance of death or at least profound disability. So when Christopher Reeve, who used to play Superman, fell off that horse and hurt his spinal cord, he also hurt his brainstem a little bit. That's called a brainstem injury, and that's why he had to be on a respirator, because his respiratory centers were damaged. Okay, so what we're seeing here is a anterior view of the medulla that has been transversely sectioned at 3 different levels. So you can see that the medulla oblongata narrows inferiorly as it approaches the spinal cord. And the reason this has been done is just to show you a couple different distinguishing features of the medulla. So 2 of them are the pyramids. So these are 2 sort of lumps, and they continue down. So they're sort of baseball bat shaped. So I'm outlining them with my pen right now. So they are some baseball bat shaped tracts, and these are large motor tracts, so that's descending information. And the pyramids are the site of decussation, bing, of most of your fibers. So your left cortex controls your right muscles and vice versa. So decussation of the pyramids is a very important anatomical feature because that's where the tracts cross over one another. The olive, which is a cute name, is also called the olivary nucleus. The olive is right here, and you can think of the olive as being underneath the pyramid. So the pyramid's sort of stuck on the front of the olives. So these neurons send input to the cerebellum, including proprioreceptive signals. So signals from your muscle spindle and from your Golgi tendon organs tell your brain about the position of your limbs and your body in 3-dimensional space. And those signals are sent to the cerebellum, and that allows your brain to compare your intended motion with your actual motion, which helps give precision to your movements. So if something's wrong with that system, let's say you have a cerebellum that's underdeveloped, that means that you can't check in with your motion as you're producing it and smooth it out. So fine motor control is impaired, and that results in an individual that is capable of moving and walking, but their movements are relatively uncoordinated compared to someone with intact cerebellar wiring. So in class, I gave you a video to look at, which was of cerebellar hypoplasia. Let me spell that out for you. So hypo means below or too few. And remember from our histology chapter, you can have hypertrophy or hyperplasia, or atrophy or hypoplasia. So trophy refers to increasing or decreasing cell size. Plasia means too few cells. So plasia is the cells portion of this. So if you have cerebellar hypoplasia, that means you don't have very many cells in your cerebellum compared with a normal individual, which impairs your ability to do this particular thing. And cerebellar hypoplasia is really common in cats, which is why you can go on YouTube and watch videos, if you search for this in cats, of what I affectionately refer to as wobble kitties. Bonus points if you adopt a wobble kitty during the term. Looking at you, Megan. All right, that's it for today. I will pick up where I left off after the next lecture.